Hello, and welcome to Emergency Medications Every Dentist Should Know, Part 4. In this lecture, we're going to talk about the other three medications that every dentist should know that are in your emergency drug kit, and they are Diphenhydramine, Solu-cortef, and then Diazepam or Midazolam. As with all of our lectures, we have a disclaimer that says you can follow what I say, and I hope you do, because this is the way I practice, but there are other opinions, other textbooks, and other sources for you that you can pursue to learn more about these subjects and find your own way to be able to treat the patient. My name is Alan Schwartz, DDS CRNA, and I'm located in Columbia, Missouri. This is an interesting picture that I saw at our botanical garden in St. Louis. This root is actually curare, and it's one of the first muscle relaxants that was used in anesthesia to paralyze skeletal muscle so that surgeons could have relaxed muscle to be able to work on. And of course, people where this was growing use this on the tips of their spears or their arrows to paralyze either animals or other human beings so that they could go ahead and harvest those beings to eat. As in all the parts, we are now in part 4. We have covered the other three parts. And again, we're talking about diphenhydramine, which is also Benadryl, Solu-cortef, and then Diazepam, Midazolam. The learning objectives for all these 4 parts are still the same. We're still going to want to follow through each of these objectives, and we have covered those before, so I'll let you read them at this time, just to refresh your memory. So let's talk about diphenhydramine. Before we begin the discussion, let's review histamine and the 3 histamine receptors. It's an endogenous, so in other words, it's made by the body substance that is synthesized by the degradation of the amino acid histidine, hence the name. So if you see the molecule on the left of histidine, you can see how it's degraded and broken so that there's only one ring, and then there is a methyl group with an amine, an NH2 on the end of it. So that is histamine. It's just a chopped up histidine amino acid. And the histamine is carried in 2 different cells within the body. The first being mast cells that are found in connective tissue, and they're also found in basophils that are circulating in the bloodstream. There's granules you can see inside these cells, and inside those granules, there's histamine, serotonin, bradykinin, and heparin. What we're going to be most concerned about is histamine and what its physiology is, what it does to the body when it's released. When there is an immune response, an infection, and a lot of different things can stimulate that immune response. There can be a mechanical injury, certain medications or chemicals that release these granules with these powerful chemicals, the histamine, serotonin, bradykinin, and the heparin that we talked about earlier. There are also antibodies attached to the mast cells and the basophils, and they are produced by B lymphocytes, these antibodies. And the antibody that we're most concerned with is IgE. And if you look at it here, it looks as though it's kind of a ring structure with a couple of tails coming out of it. And it's the tails, when they bind to the antigen or the foreign substance, that then open the granules, and then the histamine and the other chemicals pour out. So you can see there is first an initial exposure. You can see where the B lymphocytes and the IgE are attached to the mast cells or the basophils, and they are just ready for action, circulating. So when there's a re-exposure, that's when we get this profound release of histamine and the other chemicals. Here are just some other pictures that kind of give you in your mind's eye what it looks like when a mast cell contacts an allergen, an antigen. It could be a foreign protein, like we said, or some substance that triggers the release of histamine. So the mast cell then just pours out the nasty chemicals through the pores in the cell, and you could see them circulating and having their physiological effects on the patient. So in dentistry, we're concerned about the immunological stimulation due to the medications or the chemicals that the patient's going to come in contact to when we are working with them. Local anesthetics, certain cements, the smell of monomer or some perfumes that somebody's wearing, soaps, hand lotion that somebody might have used can trigger that immune response in certain patients that have been already exposed to those foreign substances. Don't forget too that during allergy season, pollens can also make their way into the air and into what the patient's breathing to give them a response to the allergy. So there are three types of histamine receptors. There's H1, H2, and H3. And their effects are, in H1, it's coronary artery vasoconstriction, bronchoconstriction, increased airway resistance, so that's where this comes from, inside the bronchioles constricting. There's going to be severe peripheral vein dilation, which means the blood pressure is going to absolutely plunge, and the peripheral arterioles also dilate, so blood pressure is going to really plunge. There's increased capillary permeability, which means that fluids and substances are going to leak out of those capillaries. Every one of these things is really bad for the patient, and if it's a severe case, it's called anaphylactic shock, and that could mean instant death for the patient. The other histamine receptor is the H2 receptor, and it has central nervous system stimulation. It can cause cardiac dysrhythmias and increased stomach acid secretion. So again, it is a real bad stimulation when that occurs. And then H3 inhibits the synthesis of histamine. So when that's stimulated, it puts a stop to things. As we said before, the allergic response to a foreign substance causes some very drastic, very rapid, very life-threatening things for the patient. It could be that instant vasodilation, capillary permeability, pouring out fluids, allowing those fluids to leak, arterial dilation. There's a plunge in blood pressure and the loss of fluids. So we're going to need to use these meds to be able to treat this allergy response. And we're going to see what those do. We're going to have decreased venous return to the heart. So we're going to be in circulatory collapse, as well as having quite an increase in stomach acid secretion. So when histamine is in normal presence in the bloodstream, it can stimulate phagocytosis, cell growth. It is a factor in the metabolism of glucose. It can cause chemotaxis, which is the attraction of certain agents to a wound to start the wound healing process, or other properties that bring substances to an area. It's involved in the sleep-wake cycle, food intake, maintenance of body temperature. It's involved in our emotions, our memory, and our learning. And I can tell you that from the studies that I've done and the readings that I've done, a lot of these things are new. I didn't even know them myself until I did the research for this topic. So there's a lot more to learn about how histamine regulates those things. Our first drug, diphenhydramine, is given to block the physiological effects of that H1 with the really bad things that are happening when H1 is stimulated. So it's going to block that stimulation. Before we give diphenhydramine or Benadryl, we're going to want to give Solu-cortef. So I'm going to put this drug in second place right now until we talk about Solu-cortef. We also have another histamine blocker called famotidine or Pepcid that is given to block the physiological effects of the H2 receptor, and there's a lot of those in the GI tract. It's a whole different receptor. We used to have the drug ranitidine or Zantac, and that has been found to cause cancer, so that was taken off the market a long while ago. So there are our two drugs. We also have diphenhydramine not only in IV format, but we also have it in pill format. And don't forget that diphenhydramine is going to produce a sedation. There is the kind of suggested dose. Again, I refer you to the Lexicon book. It's a paperback book with excellent resource for your drug dosing and what the drug does in a lot more detail than what we've given you. So the routes that we can administer it, of course, are PO for the enteral route. And then, of course, the diphenhydramine can be given IV in the parenteral route. The enteral route's going to be slower. So one of the first drugs, and I probably should have put it in first place, but I want you to think about this because it's so easy to think about diphenhydramine or Benadryl, and then of course famotidine. But we're going to need something that's going to stabilize these porous membranes. You saw those mast cells pouring out histamine. We've got what's happening to the not only those cells, but the arterioles and the venules and the capillaries that are pouring out liquid. We've got to stabilize those membranes and stop this inflammation. So one of the first drugs that we're going to give is Solu-cortef. It's also called cortisol or hydrocortisone. So it is a steroidal anti-inflammatory and is naturally produced, as we saw in part 3, in the adrenal cortex. It's one of the corticosteroids. Here's a reminder picture to show you the adrenal gland where the cortex is with the steroids that are produced. There's more than 30 produced, and the adrenal medulla, just to refresh your memory, makes the catecholamines, the two biggest one being epinephrine and norepinephrine. Not steroids at all. And here's another slide for you to remember what we talked about in part 3. Since we're at the adrenal gland, it is an adrenal corticosteroid, and it has cholesterol as a backbone. So I've shown you here the cortisol molecule and what cholesterol is, and you can see that cholesterol is part of the backbone of making cortisol. And cortisol has functions that are permissive and protective functions to allow the body to remain in homeostasis, which you recall is that stability where the body normally likes to live. It's permissive in that low doses of cortisol permit the person to respond to stress. So in a normal life, if you've got something stressful that's coming up, say you've got an exam, you've got a particularly stressful patient, you've got some stress in your life, you've got cortisol that is allowing you to be able to respond to that stress. And then in higher doses, the kind that some of us will put out if we're under constant high stress, or if you're given exogenous steroid, cortisol, and some of the other steroids like dexamethasone or solumedrol, which is also called methylprednisolone, they are a protective effect because they're anti-inflammatory and they're immunosuppressive. So it's going to stabilize membranes and stop this rush of life-threatening inflammation. So we see cortisol in the utilization of proteins, fats, and carbohydrates, meets energy needs, especially during physical or mental stress. It provides for those things for the cells. And there's a new rule that's come out in the literature. It used to be that a person that was receiving steroid exogenously to treat a certain disease, and we'll see those in just a second, it's a way for them to have extra steroid there to avert a stressful response and anxiety of dental surgery. It turns out in the new literature, the latest that I've read, is if it's not going to be an especially stressful procedure and the patient is doing well, let's say we're cementing a crown and taking off a temporary crown and cleaning the tooth beforehand, that's a relatively non-stressful procedure, and you probably wouldn't have to boost the patient with an exogenous source of Solu-cortef preoperatively IV. So if a person is given this exogenous outside their body, synthetic, if you will, cortisone, hydrocortisone, one of the adrenal steroids, if they've been taking the medication for longer than 2 weeks, it takes them 12 months for their pituitary gland to be able to stabilize, to bring their steroid level naturally that's in their body back to normal. So a lot of times you're not going to hurt the person by giving them an exogenous source of hydrocortisone, Solu-cortef. Here is a list. I won't go through it, but you will have the time to read this, of some of the diseases and disorders that people have that are given the exogenous corticosteroids. So I'll let you look at those. There's endocrine disorders. There's rheumatic disorders, allergic states, ophthalmic diseases, steroids are given, gastrointestinal diseases, respiratory diseases, hematologic disorders, neoplastic diseases, edematous states, and then there's just miscellaneous states. So without that boost of some exogenous corticosteroid, the cardiovascular system can and will collapse more than likely. And it's the first treatment, as we said, for anaphylactic shock. We're going to add very quickly diphenhydramine, famotidine, and then epinephrine in severe cases of allergy. So we're going to be blocking a lot of receptors and providing for the stress of the immunologic response. Here is the dose for Solu-cortef and the usages that we talked about earlier with those slides. This picture of me grasping the Solu-cortef bottle is a movie, and you'll be able to activate that and see how to activate these bottles because they all come that way. Solumedrol, Solu-cortef come with this, where there's liquid water in the top section, there's a rubber stopper, and then there's powdered hydrocortisone or methylprednisolone down in the very bottom. You shake it, pop the little top off, and then go ahead and draw the drug up into your syringe and give it IV. The drug can be given parenterally, either intramuscular or intravenous, as well as intraosseous. Let's talk now about Midazolam, which is Versed, and Diazepam, which is Valium. You're going to see this in your drug toolbox, and you'll see this in multiple places. I just want you to have this as part of your emergency drug kit. So remember that these two drugs are in the controlled Schedule 5 classification, and they are narcotic substances, and they should be kept separate and locked up, and very, very quickly, if needed, be able to get in and administer these drugs to the patient. So they are used in anesthesia to reduce anxiety. They provide sedation, and increased sedation if it's in a higher dose, of course, skeletal muscle relaxation, so they're muscle relaxers, and they do provide some amnesia. Realize that we don't, with a sedation case, guarantee amnesia. We'll talk about retrograde and anterograde amnesia in the other lectures that you've had. But retrograde amnesia means if you've got a point which is now, you're not going to even remember coming into or the events approaching now if you've got retrograde amnesia. Anterograde amnesia is what happens after now, where you have the time marching forward and you don't remember things. So both Versed and Diazepam, Midazolam and Diazepam, can occupy the receptors the GABA receptors in the brain. GABA type A, GABA stands for gamma aminobutyric acid, and it's going to stop the tonic-clonic seizure activity. Tonic is when there is tone, and so the person is stiff, as you can see, and then there's a relaxed phase, and that's called the clonic phase. So it's going to put an instant end to these seizures. This is a picture of the GABA type A receptor in the brain. There's a lot of familiar drugs that bind somewhere along this receptor to distort it so that it then becomes a free channel with chloride ions flowing from the inside of the cell to the outside. So there's not any neurotransmission. So that's where the volatile anesthetics work. There's a receptor for propofol, barbiturates, the benzodiazepines such as Midazolam and Diazepam. GABA itself binds there and reduces pain. And then an induction drug that we use in anesthesia called etomidate has its own receptor that binds to this important receptor in the brain. So chloride channels are open, the membrane and the neurons hyperpolarize, and there's just not any transmission of any neural activity. So this is what produces the stop in seizures, the stop in brain function so that the person is in an artificial sleep, be it through a gas, be it through something like propofol or the benzodiazepines. This is just a picture so that you can see who invented the first benzodiazepine, and that was Dr. Leo Sternbach. So it was quite an important discovery. And the first drug that was released was Librium, and it's still on the market, and that was released in 1960. Valium is still on the market, and that was released in 63. It's got a nice long half-life, as we'll see in just a bit. This is a list of some of maybe the upcoming or benzodiazepines we may never see. So you might want to take a couple of seconds to look through and see the different benzodiazepines that either have been released or they have been removed from the market. There is Dalmane or flurazepam that is in the middle of the diagram. It's slightly toward the top, but you'll see flurazepam, and that was removed from the market. It had some, believe it was either cancerous effects, and it had some deleterious effects on the heart. It was some really bad stuff, so that's not around anymore. These cone diagrams show you the half-life in visual format for some of the different benzodiazepines that we use, like midazolam, diazepam, triazolam, which is halcyon, lorazepam, which is Ativan, and alprazolam is Xanax. So you can see that if you're quickly needing to reverse using flumazenil, you haven't got a very long half-life for these patients. And you'll probably have to redose it and keep an eye on the patient until they stabilize, till they're no longer feeling the effects of the sedation. Now, if you're giving midazolam or diazepam, realize for a seizure activity that they're going to also produce sedation in these people. So you're going to have to support the breathing, the oxygenation, and the blood pressure in these patients. And of course, we don't want to reverse them, but we're going to have 911 along the way so that we can get the patient quickly to the hospital if they've experienced this grand mal seizure. Don't forget, too, that if you have a patient that leaves your office via 911, that a lot of dental boards require you to submit a written report within 5 business days, and they have a form that you fill out outlining what happened, what you did, and what precipitated the emergent event. Realize also that the benzos, the benzodiazepines, are used off-label for treating seizures. So the epileptic seizures can be foci that are localized within the brain. They're abnormal electrical discharges within certain areas of the brain. Maybe it's something that was hereditary or something from an accident that precipitates these focal or localized areas. And they can be transmitted all through the brain, causing that contraction or tonus, and then the seizure where there's the clonus, where there is muscle relaxation. It's involuntary. So when those occur, they're called grand mal seizures. And they can be precipitated by such things in the dental office as a strong emotional stimulus, stress, rapid breathing, medications or illegal drugs the patient's taking, fever, loud noises, or even being NPO. So remember that you want to position the patient flat in the dental chair. Don't have anything sharp like the air water syringe or any sharp dental instruments, needles, syringes around, so that if there is violent movement, that they're not going to hurt themselves. I would get a number of vials of Midazolam out if that's all you've got, or the bottle of Diazepam. Diazepam's half-life is 48 hours, so you'll probably only need one vial of that. But you may need to redose the Midazolam because of its half-life, 2 to 6 hours. So you're going to want to draw up the Midazolam and then the 2 milliliters of Diazepam, which either one you use, and then rapidly inject that IV. And our goals are to assist the patient maintaining their airway, breathing, and circulation until the emergency 911 people get there. We're going to want to stop the seizure activity. It's dangerous. It can be bad for a person to seize for a long period of time. They're going to be using up a lot of ATP and a lot of glucose, and we can run into some major issues with the patient, some emergent issues other than the seizure activity. And of course, we don't want the patient to get injured in our care, so we want to clear a path for them and make it right so that they don't hurt themselves. Treatment things that I have found in my literature search are to loosen tight clothing, cushion their head because they're going to be seizing back and forth and up and down if they're on a hard floor. And if you can't get them to the ground because they're going to be turning right, left, sitting up, stretching, going into that clonic activity, and we don't want them to get caught up in any of the hoses, wires, and things in our dental units. If you have to let them be in the dental chair and you can't get them to the ground, just go ahead and have people stand around the chair and protect them. We turn the patient to the side, and usually the left side would be the better way to turn in case the patient vomits. And you'll see why in some of our other lectures. It's because of the shape of the mainstem bronchus and then the left and right mainstem bronchi. We don't want to use benzodiazepines in pregnancy. If you have a pregnant patient that is also prone to seizures, then we might want to consider very much postponing the dental procedure, because if there could be seizure activity during the procedure, then we really can't use benzodiazepines for that, because benzodiazepines can cause teratogenicity in the fetus and cleft palate as the head and the face and the mouth are developing through embryology. So what would you do then for these pregnant seizure-prone patients? I wouldn't hesitate to get a consult from a physician. Tell them what you're going to be doing, fill out the top half of the form, the health concern that you've got, the med that they're taking, the fact that you know you can't give a benzo to this patient. What should you do? And then the physician will probably tune them up and have them make sure that they're on their anti-seizure medication that they're already taking each day at home. So there are the suggested doses for the Midazolam and the Diazepam. And the drugs are given either parenteral, intramuscular, or intraosseous. I keep mentioning intraosseous. I know we're not going to see that in the dental office, but I like to be complete. So here is your quick and dirty drug cheat sheet. We've got diphenhydramine on this particular list that we've been building. We've got Solu-cortef, Diazepam, and Midazolam on this first sheet. And then on the very last sheet, I've kind of updated Diazepam and Midazolam again with a little bit more information. Lastly, I want to show you what the Lexicomp Drug Information Handbook looks like. It looks to be around $70 or so for the book, and it's just a great source for you to be able to refer to any of the drugs the patient might be taking and any of the drugs that we're talking about in each of your lectures for your course. So I thank you for taking this course.